I'll just turn it over to Doug Crawford. Thanks.
Okay, and Dr. Kurt Anderson, who joined me, our Chief Medical Officer, and I are going to tag team this. So I'll give maybe 5 to 7 minutes of kind of an overview of what's happening with COVID that changes, frankly, every single day. Every single day is an adventure and very dynamic. And then I'm going to turn it over to Dr. Anderson, and he can talk about things in addition to what I've highlighted. And then we're going to answer questions until almost 5 o'clock if we want to go that long. So first of all, let me just thank you for your relationship with Genesis and for your engagement and for taking the time to join us today to get the facts of what's going on. There's a lot of misinformation about COVID. I run into that all the time. And we're going to tell you what's really going on. I was just on the nursing unit an hour ago, literally, talking to 30 nurses on one of our units that we've converted to a COVID unit that used to be an orthopedic unit. So first of all, yesterday, I guess it's not yesterday, 2 days ago, we hit our peak of patients, and that was 131 for a census. So that was on Monday. Today we've come down just a little bit from 131. We are at 120. To give you an idea of how much higher that is than it was earlier, I looked up October 1st and we were at 25. So we have grown from 25 up to 130. Literally, if you look at the graph and go October 1st all the way back to March 15th when this started, when the first patient, that was the first patient in Iowa, it's almost consistently between 25 and about 10. We had a low of 10. I think we hit a few days that we had close to 0. So we go very, very, very low, and then you hit October 15th, and it just goes exponentially higher. Up until Monday, almost every day, up until Tuesday, almost every day we were increasing. Tuesday, it went down from 131 to 126, and from yesterday to today, down to 120. That's a good sign, but 2 days doesn't make a trend, so we're still concerned. To give you an idea of in admissions, how many people came into the hospital on average every day, if you look at the whole time, March 15th, October 15th, it averages about 3 a day. If you look at the last 7 days, it averages 20 a day.
Wow.
7 times. We're averaging 7 times as many people getting admitted to the hospital. Now, another fact. Up until November 1, our admission rate was running at 15% of all of our positive patients. Pretty typical for the country. Due to some things we've put in place, that's dropped down to about 8%. So that's very good news, because if it were at 15%, we'd really have a problem, and we'd be up closer to 200 right now rather than 130. Let me just summarize for you some of the actions we've taken, and actually this is a list of just the last week. It's just such a whirlwind. Even in the last week, there's just a huge number of things that we've done. First of all, the orthopedic unit at GMC Davenport, because we've discontinued doing elective procedures, elective surgical procedures, is now our second COVID unit, completely dedicated to COVID. And it's a 32-bed unit that we've converted now into double rooms. So that allows us to have about 60 patients on that unit. The other unit is medical pulmonary. That's always been our COVID unit from March 15th onward, and they average almost 60 every day. So those 2 units make up the main COVID medical units for GMC Davenport and can hold almost 120 patients. So that's been converted, and which means the staff is converted as well. In addition, we've had other staff join them from various parts of the system. Some non-clinical nurses have joined them as well. Next, we have increased our intensive care capacity. The most difficult thing for us right now is intensive care staff and somewhat beds, but beds are an easier part than staff. We've increased our capacity from 20 to 26. We're never budgeted for 20. We were budgeted to average this year pre-COVID 14. So the staff was built to a census of 14, and we're running essentially double that. That's a real challenge, and a lot of people are picking up a lot of time in our ICU. I mentioned earlier, we have a temporary reduction in elective surgical cases. We've also temporarily discontinued our pediatric unit. And pediatrics is something, inpatient pediatrics is something that we could fairly easily stop doing, sending those patients either to Trinity Bettendorf, they still have a pediatric inpatient unit, and or the University of Iowa Children's Hospital, and then we can reallocate those staff. We've put in tremendous staffing incentives, and I just got the number from Jordan at GMC Davenport to incentivize people to pick up shifts on these COVID units. So there's essentially 5 COVID units, if I can get my hand up there. So there's the ICU at Silvis, the medical unit at Silvis, the COVID unit number 1, which is the medical pulmonary unit with a capacity of 60, COVID unit number 2, which is the orthopedic unit, and then the ICU that has a capacity of 26. There's 5 units that people are working on. We give incentives for as much as, drum roll please, $225 if you will pick up a 12-hour shift. We spent $120,000 at Davenport alone this last pay period on those nursing incentives. And it's a good thing because we were able to staff the hospital. We are super busy, but financially we're super busy with the wrong business. And we can talk about those rumors that we're making a lot of money off of COVID, which is not the case. We've moved to a team nursing model, and we can talk about that a little bit more. I worked in healthcare for 39 years. Models kind of wax and wane a little bit, but for the most part, while I worked in hospitals for those 39 years, we've been in primary nursing, which means one nurse with the help of a patient care tech is going to probably take during the day 4 to 5 patients. 5 would be high, 4 would be the normal assignment. What we do now is we have a team of nurses, one super nurse, very experienced, with maybe 2 or 3 other less experienced nurses. Maybe those people worked as care coordinators before. They're RNs, and they worked 20 years ago on the floor. I'm making this up, but it's a true story. And they're going to come back and help out because they're incredible, and we've had 120 people step forward. And so they then take care, that team with patient care techs and some non-clinical people may take care of as many as 15 to 20 medical patients. And so then on that unit, we may have 3 teams rather than primary nursing. Take 60, divided by 4, that's how many primary nurses you would need. So primary nursing assumes that the nurse is capable, qualified, and competent to care for those individuals. And that's simply not true if somebody steps forward and works in the clinic now and they worked on the medical pulmonary unit 10 years ago. They don't have the same level of skills anymore to take care of a COVID-type patient. And so that's how we make that work. It's called team nursing. I want to say a little bit more, and I'm going to read you a quick story, and then I'll turn it over to Dr. Anderson. I want to say a little bit more about this Safe at Home program. The university, we'll give them credit, University of Iowa, told us about this about 3 weeks ago. Within 5 days, because Dr. Anderson and his team is amazing, they stood up this program in a 5-day time frame, and we now have 382 patients as of today enrolled. It's been operating for 14 days. 26 have been safely discharged from the program. And I told you earlier what our admission rate was going into November 1, right around 15%. These are the highest risk patients, and our admission rate with these patients is 2%. With an average admission time, normally, after someone is positive of 5 days. So this has dramatically reduced our admissions. It's an incredible program that we've used in order to take better care of these people at home, in this case, 382 people. So there have been 7 hospital admissions in the last 14 days from that group of 382. So I'm just gonna read you an interview that was done with one of the patients. Even though she hadn't been feeling well, the 76-year-old Davenport woman refused to see a doctor. At the urging of her blank, I'm not gonna say her name, daughter, a relative paid her a visit in early November. She checked my oxygen level and temperature and told me, "You're not staying here, you're going to the hospital." At Genesis, so-and-so learned that not only did she have the COVID-19 virus, she also had pneumonia. She was admitted to the East Rush Home Genesis Davenport East Campus, where she was a patient for 5 days. The care I got was excellent, she said. While I was up on the 6th floor, that's the COVID unit, all of them, her care team, were great. With her health improving, she was released from the hospital on November 11th and placed in the Safe at Home program, where patients continue their recovery working with a treatment team of nurses, physicians, and support staff that check on most of these people every day. And they get equipment too that helps them know and monitor themselves. As part of the program, the patients are giving home testing equipment, including a pulse oximeter, blood pressure monitor, thermometer, and a symptom log sheet. This equipment allows the individual to be monitored and report their vitals when called or visited. Being in the program gave her peace of mind that every day everything was under control. It's been great, and I'm so happy that with the way I've been treated, she said, I feel like I was going to get better because they were so on top of all things. It gave me a lot of confidence. I feel better now than I did for a long time before I went to the hospital. I'm just amazed that they're getting me all fixed up. They did miracles as far as I'm concerned. I just received that today, and I wanted to share it with you because it's such a great testimonial. Literally, there are hundreds of things that we've done. Every day we run an instant command model, if you're familiar with disaster scenarios. I lead that myself. Every day we have a list of issues. We address those issues in a 24-hour time frame. It's been an amazing time. I've never seen anything like it, and we're happy later to answer your questions. Dr. Anderson.
Thanks, Doug. I would just echo some of what Doug said about the amazing ability and resilience of our teams. Whether you're talking about the outpatient team setting up programs like the COVID Safe at Home program, or you're talking about the inpatient units that just continue to take on more and more COVID patients. And these are very, very sick patients. We're providing a level of care on our medical unit for many of these patients that in the past would have automatically qualified them to be in our intensive care unit. And the patients in our intensive care unit are incredibly sick, the COVID patients, which represents almost all of our intensive care unit beds at this time. So we have some amazing teams, and I think what we need from the community, and if you're going to be our ambassadors, which I'm sure you will be, we need the community to do their part to slow down the spread of the virus in the community, because I don't care how incredible our teams are, they're not infinite, and we only have so many people that can do the work. And we have our own issues with our team members getting sick from COVID-19 and affecting our ability to provide care. So we're pushing everybody as hard as we can, and they're responding, and everybody's mission driven at Genesis. But there's a limit to that, and that's what I worry about, and that's what keeps me awake at night.
Do you want to say any more, Dr. Anderson?
No, only if there's an area anyone wants me to highlight of what Doug has talked about, or we'll take any questions.
Yeah, let's just take questions, and you can direct it to either one of us.
I have a question for you, Dr. Anderson, maybe Doug, and just to start, can you hear me?
Yes.
Yes. Go ahead, Mark.
It's Mark Bawden. Before we got on, a few minutes before we got on, Missy and Chris Cox were talking about how we need to get the word out, and people need to wear masks, and this community needs to do what they can to support healthcare workers, and I agree with all that. But I think the ironic thing is, and maybe you could comment on this, is that it seems to me over the last month, I've never seen more masks, and I've never seen and talked to people more who are isolating. Almost everybody's isolating and taking it very seriously, and yet it continues to grow exponentially, even as we are kind of jumping on everybody in the community to wear masks and being so firm about it. Is there more going on than just masks? I mean, is there something else going on that's taking it to these astronomical numbers? Because it seems like most people are taking it pretty seriously.
Yeah,
Dr. Anderson, you want to take that, and then I'll add some things?
Yeah, I'll take a shot at that. I think there's lots of factors, Mark. I think there are groups of people that are doing very well, and then there are groups that are not doing as well. I've certainly seen a lot of places where restaurant parking lots are packed, and there's no way you can safely be in the restaurant with 40, 50, 80 people with a respiratory spread virus. It's just not, it's not possible. It's a dream to think that you can do that and do that safely. And now that we're more indoors, we anticipated that we'd have more problems when we had to be more in confined spaces, because you dilute out the virus when you're in a larger environment, and your risk of coming in contact with the virus goes down. So some of it I think we could have known, and we did know. We knew there would be another surge when we went into the fall and winter season. But I think some of it is still some responsibility that we're not really taking. I mean, gatherings where you're having 20 family members in a household that all have various activities that keep them away from home, that might increase their exposure risk. I think those kind of things, gatherings in homes, being out in restaurants, are places where people kind of have decided, well, I think it's probably safe. But remember, most of the community hasn't been exposed to the virus, so we're all still susceptible to this. And now we're just seeing it, more and more people getting sick. And then it doesn't take very many people to propagate the spread of the virus.
Yeah, if you look at, just some numbers to give you an idea, we've had to date 761 inpatient admissions. So it doesn't take a lot, that's as of Monday. It doesn't take a lot of people staying, a fair number of days. The average ICU length of stay for some of those admissions is like 15 days. So, you get 1,000 people, you're going to overwhelm a hospital system that's the size of Genesis. That's the problem. And what Dr. Anderson said, I think, is exactly correct. It's not all the community, but it's some of the community, and they're completely irresponsible. I'll tell you 2 stories. These are directly, one was from today and one was from last week. When I'm on the nursing units, I say, tell me how the patients tell you they think they caught COVID. So I was in one of the hospitals last week, and they told me, well, there was a birthday party for a 70-year-old. There were 50 people there. Most of the people didn't have masks on. 16 so far are positive. 2 of those patients died. Okay, that's just one birthday party. Just what Dr. Anderson said, I was driving by the TBK Center with all those restaurants out there on Saturday night, packed. I just drove by because that's my house. My house is out there, absolutely packed. Today, again, I'm on the ortho unit, one of the COVID units. I said to the nurses, tell me a story today about how someone caught it. And they said, well, they really didn't know. And then I asked them the question of, well, did you ever wear a mask? Well, no, I didn't wear a mask. Well, there you go. There you go. So there are 5,000 people so far that have caught COVID that have been tested by Genesis, approximately. 761 of those have been hospitalized, and that's as many as it takes to overwhelm a healthcare system. So we're talking about the behavior of at least, these 5,000 people, when the community probably has 500,000 if you go out a ways. And you multiply those numbers times 2, as Trinity is probably caring for similar numbers that we are. So we thank everybody, but you really need 100% compliance, to drive something down and to really turn this thing around.
And I think the other thing that I would just add is, it becomes a math problem. When we have a 2% or 3% rate of positive cases in the community, your likelihood of getting exposed when you're out in the community is pretty low. When we're up, approaching 20% and above, now your probability is a lot different. So we start to see the virus spread much more quickly, and then we're also fighting some fatigue, where people are just tired of not doing the things that they want to do, and they think, well, I've gotten by this far and I've been okay, so I'm just gonna, if I want to go out for dinner,
I'm listening to the Genesis.
So I think we're fighting those factors.
Yeah, and it's hard because it's been 9 months, right? March 15th to November 15th. It's hard to believe, but it's 9 months already, so everybody's fatigued.
Dr. Anderson, when we set up this call, we were intentional about inviting you to speak about seniors in particular, and we have had some questions sent to us, but I wanted to give you an opportunity to talk a little bit about why our seniors are more at risk, what's happening in our senior community, especially in our senior living facilities, and what we're doing, especially to protect those individuals.
Sure. So I think what, the first thing is, whether we're talking about COVID or whether we're talking about influenza or almost any other infectious process, as we get older, we're just more prone to those infections. Some of it's our immunity and our degree of immune system function. Some of it's just the things that we've accumulated throughout our life that increase our risk of getting more sick from a virus or a bacterial infection, whether that be diabetes, high blood pressure, kidney problems, heart problems. So those factors kind of stack up on us as we get older. And this virus, like many, is much more dangerous in the older age groups. Much higher percentage of hospitalizations and much higher percentage of death occur in patients certainly above 60 and even more so above 80. So we see that that's just an at-risk population. It's also the same population that's at risk during influenza. Just happens to be that COVID is 4 to 5 times more dangerous for even that population. So we just have to try to protect the senior population even more so than we do the rest of the community. And I think we've worked really well. Glenn Roebuck has really been our liaison and champion within the senior services realm and in our partners in the community to try to keep the nursing home patients and skilled care patients as safe as possible, and also when they've had outbreaks to try to contain them and manage them within the facilities so that they don't spill over into the rest of the community or overwhelm the hospital. So I think we've done a really good job with that. I think other communities have struggled with that more than we have, and I think it's due a lot to the partnerships that we have with those care facilities, and Glenn gets a lot of the credit for that.
Yeah, thank you, Glenn. Let me just put a statistic onto Dr. Anderson's comments. I've shared this on the TV. These are our statistics, but they're very consistent with national statistics. If you get COVID, if you're positive, again, we talked about this, not everybody's admitted, right? It's running at about 8% right now. If you get COVID and you're under the age of 60, your likelihood of being admitted is 10%. If you're under the age of 40, it's actually 3%. If you're over the age of 80, it goes up to 60%. So that's why we tell people, if you're older, you need to be super careful, because if you get exposed and it's positive, your likelihood of getting admitted is so much higher. We'll all watch and see what happens with Chuck Grassley, Senator Grassley, 87 years old. Our statistics for those people, their likelihood of admission is really high, and then their likelihood of getting very sick and even mortality is much, much higher than the rest of the population.
Another question that we had, thank you, Doug, from an individual: how many people are dying of COVID only, meaning from COVID, not merely with COVID?
Well, I'll answer this, and then Dr. Anderson can answer the complexity of that. But again, 761 patients, and so far 48 have died within Genesis. That's a 6.5% mortality rate. But Dr. Anderson, what about the dying with COVID versus from COVID?
Yeah, it's an interesting discussion. I had looked earlier in the year to see where we were running compared to the normal deaths in a similar year, and I looked at that before we're doing this call today, and looked at the October data from the CDC, and we're running about 300,000 more deaths than normal in our country for 2020 compared to previous years. And they factor in all the other variables, but the one variable that's different is COVID. So our reported COVID deaths are actually below that number. So we're probably, if anything, underreporting deaths from COVID. Now, we know there are also some deaths that are occurring because COVID is preventing people from coming in to get care for other problems or delaying their care for other problems. So there's kind of a side effect of COVID as well on mortality in our country. But the thing that's interesting to me is that we have this debate about whether you died from COVID or didn't die from COVID. I don't ever remember having a similar debate when people die from influenza or from anything else. If I walk across the street and get hit by a bus, I think I died because I got hit by a bus, not because I'm overweight and take a blood pressure medicine. So it's not exactly that simple, and that's a little tongue in cheek. But the reality is, yes, if you have other conditions that put you at higher risk of infections, whether that be age, heart disease, obesity, lung disease, kidney disease, yeah, you are more likely that if you catch COVID, you're going to do worse with it and you may die from COVID. The funny thing about COVID, though, is we have people who seem to be otherwise pretty healthy, and they do terrible with COVID. They get really sick, and some of them die, and some of them are young. So it's an interesting pathogen. It doesn't act exactly like things that we've seen in the past. The other point I would make is if I'm a 73-year-old diabetic and maybe I'm a former smoker and I have a little COPD, but I'm well controlled in my daily life. I'm fully active and doing everything I want to do on a daily basis. And then I get COVID and I end up in the intensive care unit for 3 weeks and they can't pull me through and I die. Well, yeah, I guess you could say I died from everything else, but I was doing pretty good before I got COVID. So it's pretty hard to I just don't put much weight into that argument of, well, they're not really dying from COVID. I mean, okay, I guess we'll have to count only people that die that get hit by buses are people that are young and have no medical problems.
You know, just to put another point on that, just take our ICU. So today we had at the beginning of the day, 24 patients in the ICU, 18 of them were there because of COVID. That's amazing. I can't think of anything ever in my career, maybe Dr. Anderson can, where there was ever an issue that filled up the ICU like that. That was unrelated to normal business. 18 of 24 patients in the ICU were there because of COVID. It's unheard of.
Another question, maybe this one's a bit more of a soft toss. We had an individual reach out that said mail and packages coming by UPS and FedEx, should the outside of these be wiped down or let sit for a day or so before opening? And this person is still wiping all grocery store items. Does that need to be done? And I guess that goes to, how is this spreading?
Dr. Anderson.
Yeah, I mean, I'm not going to tell anybody that they shouldn't use whatever overabundance of caution if that's what they feel it makes them feel more safe. I think we are pretty set that the majority of cases are occurring through respiratory spread, not from contact spread. Having said that, is there zero chance you could get the virus from contact spread? No, it's various degrees of risk. So I think that that for some people, that's going to be more than they're willing to do to get to that very, very, very last little bit of risk elimination. For others, if they want to wipe down things, I think that's their prerogative, but I don't think that's our major mode of transmission. It's respiratory spread, predominantly droplet spread.
And the statistic that I've heard is if you're with someone with COVID for more than 15 minutes, 6 feet or closer, it's a high risk of catching it.
Another question that was sent to us, Dr. Anderson. In the book, Being Mortal, it talks about the importance of looking at seniors' feet as a telltale sign of wellness or not. Do you subscribe to this theory in practice? And if so, is it being utilized enough in your opinion?
Now, I'm not strong in podiatry, but we do look at people's feet. You know, I think the point there is there's a lot you can tell there. So if you have good circulation, if you have good hair growth all the way down to your toes, another sign of good circulation. If you're physically active and ambulatory, you're going to tell a lot. So I think it's a marker of how someone's doing overall, and it's something that's fairly easily observable. So you don't need to do fancy tests or anything like that. Are we utilizing it enough? I don't really know the answer to that. It depends on what the condition is and how that's going to impact it. But I think in general, my thought on that is that if you're healthy and active and you stay as active as possible, your feet can be an indicator of your overall health based on all the factors we talked about, circulatory being a big one.
Another question, thank you. Are you seeing any patients that have had COVID seemingly recover, but then are coming in with a stroke or blood clots?
So we know COVID has this weird propensity for causing people to have blood clots. Usually we think it's during the active infection and then the inflammatory response triggered by the infection. I don't know I don't think I've seen in our own experience, at least I haven't had it brought to my attention, that we're seeing patients recovered then returning with strokes or pulmonary embolisms or other blood clots. But certainly the patients we're actively managing in the hospital have had a much higher rate of those kind of complications. And everybody's trying to figure out what the right treatment is for that. Should everybody that has COVID be placed on blood thinners if they're hospitalized? How much of a blood thinner? How strong of a blood thinner? Those are the questions that are being worldwide addressed. I would say we tend to use anticoagulation much more frequently in this patient population than we do some of the other illnesses like influenza, for example.
I think we should probably talk about vaccine. There's been a lot of news out in the past week about the vaccines and how the government is going to be approving those. And then the next question, or perhaps two questions. One, what do you think the odds are that people will take the vaccine? And two, what's your crystal ball tell you about distribution?
Dr. Anderson, you know quite a bit about that, and then I can chime in.
Yeah, we're preparing for distribution. It's likely to come in waves as the vaccine supply increases. That first wave, if everything goes well with both manufacturers, will probably cover up to 20 million Americans. Mm-hmm. And that'll be the high-risk groups and the kind of the frontline healthcare workers and other frontline first responders. So that list hasn't yet been released, but we can all kind of guess how that prioritization list is going to go. But we think we're going to have vaccine in December. Whether it comes on the first half of December or the second half, I think is still debatable. I'm leaning towards second half, but I could be surprised. And we're building our distribution plans in our community in partnership with the health department, both Rock Island County, Scott County, with Unity Point and with CHC. So those meetings are happening on a regular basis so that we'll be ready when the vaccine comes to be, again, that first wave of immunizations. The second one's a lot harder question to answer. I think it will depend on how effective, hopefully it will depend on how effective the vaccine is. We know the early data shows that the two vaccines that are the furthest along in our country look to be very, very effective. And I think if we have a very, very effective vaccine that starts to be widely used in our country and people are doing well with the vaccine, I think you'll see a snowball effect of more and more members of our community willing to get that vaccine. So that would be my hope. And, but we're going to have some work to do. We're going to have some public education to do. I was talking with our group today, an internal team working on our vaccine plan, just about our own internal communication and education to our employees to make them feel like it's safe and that they can get the vaccine and protect themselves.
Yeah, the two vaccines that have been talked about within the last week to be effective, one 95% effective, the other 90% effective. That's really tremendous statistics. And like Dr. Anderson said, we think 20 million will be released probably before the end of the year if everything goes well. And we were told today that one of the vaccines is making application to the FDA for approval, emergency use for approval. The distributor and administrator of the vaccines are the health systems and hospitals within the United States, with the exceptions of the nursing homes where the contract is with CVS and Walgreens. So we will be giving the vaccine. It'll be given once it's given to the general public, through our physicians, and then likely in a central location for those who don't have a doctor. It's going to take a while to get everybody the vaccine. There's 2 doses that will need to be administered. One of the vaccines has to be super cooled at like 170 degrees below zero. We have freezers for that we bought specifically, knowing that we would be the distribution and administration arm. So it'll be very interesting. Just another story that maybe surprised me, might surprise you. When I'm up on the nursing unit, people want to talk with me about the vaccine. And usually the question they ask is, are you going to make it mandatory? Because the flu vaccine is mandatory at Genesis. And my answer to that is no. And I was asking Dr. Anderson this question the other day, and he said something to me. What did you say, Dr. Anderson? Should it be mandatory?
Well, I said, well, I don't want to be rude. I mean,
okay, well, no, it's just funny. He said, only if you're smart, it should be mandatory.
Yeah,
right. So I'll be the first in line. But it's interesting to me how many employees, and these are healthcare workers, have pushed back just because they get worried about the safety. to go back to the campaign that Dr. Anderson talked about, we're going to have to show the American Hospital Association, the American Medical Association, the federal government is going to have to talk about the safety of this vaccine. But once it goes through the process, I'm first in line.
Good, thank you. We've had another question. What would you suggest for staff burnout, and what are you doing about it within the health system?
Oh my, there's so many things we're doing, and I'm going to be very specific to the group I just talked with, because I just finished talking with those 30 nurses about this specific issue. So the number one thing they want is to not work as much. Number one. We feed the 5 units that I talked about, we feed them every single meal. So they do not have to go down and get food. We bring food to them. It's all free. We have tons of snacks and drinks that are provided to them, and that's all done by the food service department and a group we call the Compassion Crew. There's other things that are done, special treats, cookies, and everything else that you imagine is brought in. I actually pitched them the idea that Mark Bodden and I'm going to talk with Mark after, talked about of whether they would like to have a buddy who would provide them acts of kindness. And I asked the 30 nurses, this is so interesting. I described it to them and I said, someone would be assigned to you, they may grocery shop for you, put up your Christmas lights, do this or this, massage your feet. I made that one up. And I said, how many are interested in that? And nobody raised their hand. Nobody raised their hand, not even one. And I said, well, guys, what do you want? And they said, we want help. We want help. We just want to work less. So I think we're providing them everything that we can think of, accolades, food. They just want to work less, and they just want to take care of fewer patients. Some of these people are working more than 120 hours per pay period, which would be 20 hours of overtime every single week. And for them, that's just gotten old. So we just need more nurses and more patient care techs. And that's one reason why we've decreased the number of elective procedures that we're doing, and we're having people come from all these other areas to free up additional people that can help out on the nursing stations, even though they don't have the same level of training and expertise that the current people have. So there's some things we're doing with gift certificates and others, and it's all being very well received. They're very appreciative, but that's what they really want. They really want to work less.
And I know that we're doing a lot of recruitment all the time. It's not just something that we've done around COVID.
Well, and some of the other things we've done, we reached out to every single nurse who retired, I think it's within the last 5 years, to ask them if they would come back. So I can tell you, you think of an idea, we've already thought of it and implemented it. And that gets back to asking people to pick up additional shifts that work from other areas, and that goes back to the $225 as a bonus. That's not the compensation, that's the bonus in addition to the compensation if they'll come and help out people with on the floor. So I have another story. I have an administrative fellow that works with me that happens to be a nurse. Her name is Ann Voss. I have 2 that work with me. Ann came out of the quality department and decided to, she buys into the mission. She stepped up and worked both Saturday and Sunday this last weekend. That's part of what's happening to help these people out.
Green.
But the problem is we've gone from 20 patients to 130. The need is enormous. We just hope we don't go to 200. And so the biggest help you can do, if someone says to you, how can I help? I would say to them, wear a mask. Wear a mask. That's how you can help. Wash your hands, social distance, don't go out in groups. The biggest way you can help our people is to follow the guidelines.
Well, we've got about 3 minutes left, and I know there may be other burning questions. I'm happy to take one. If you just light up, raise your hand, let me know that you have a question. If not, we'll toss one more over to Dr. Anderson. Dr. Anderson, there's a lot of stress because of the isolation. People are very sad about the holidays coming up. This is especially difficult for seniors who have been shut away from their loved ones, their grandchildren, their great-grandchildren for several months now. And I'm just wondering if you, having had a private practice, if you have anything that you would recommend for that particular population.
Yeah, I think it's especially hard on that population, and you know, everyone is struggling with not being around family as much as they're used to, or having to do that through a phone, you know, through a FaceTime or other activities. So I think all I can say is try to reach out in whatever way you can and be involved in that family member's life. You know, the reality is that gathering with them in a group where some of the family members may have COVID and not know it seems really irresponsible and not safe at this time. So you have to find other ways to do that, and know that, you know, there is a light at the end of the tunnel. We're not going to be in this forever. I do think the vaccines will be effective, and I do think over time we'll get a large amount of the population immunized to the point that we can see the virus rates low enough that hopefully by next spring and summer, we're back to what seems like a more normal life. But in the meantime, we all have to do our part to protect the most vulnerable members of our families.
Sage advice. Again, I want to thank Doug Cropper and Dr. Kurt Anderson for taking time out of their very busy days to be with us. The next time that we'll have our Doug in the dock, it will be with Dr. Bill Langley, that I know most of us, if not all of us, know, and that will be on December 10th. So if I don't see you before then, just wish you a very happy and safe Thanksgiving, and thank you for sharing the messages that you can to help take the burden from the hospitals and keep people healthy.
Thank you.
Thanks, everyone.